So, good day, Sir Patrick and classmates. Together with Tuan and Stephen, we are Group 6, continuing our presentation, our chosen healthcare organizations, total quality management issue. So, as a recap, in our previous YouTube video upload, we presented the background of our chosen facility, which is the ambulatory chemotherapy unit of Quirino Memorial Medical Center in Quezon City. We also discussed the external internal environmental scan of our facility with a bias on the patient satisfaction survey, which we used as a basis of our quality management issue. We completed our report by presenting our root cause analysis using the four-piece Ishikawa diagram. So allow me to quickly review our facility's patient satisfaction survey, which became the basis of our quality management issue. Highlighted here in yellow box is the survey question, which received the least satisfaction among our patients, receiving a mark of 90.52%. While the score seems acceptable, we can understand more the prevalence of this issue when we compare this with the result of the survey done the preceding year. So this graph compares the previously presented survey from the immediate past year. Notice that the target for our facility is set at 90%, which means that the survey question of interest is in fact within the target. However, compared to the previous year, as shown here, the same item has shown a decrease in trend, suggesting a decrease in satisfaction on the way follow-up plan is conducted in our facility. Important to note as well that among all aspects of care included in the survey, the item on the follow-up planning remained to receive the lowest satisfaction rates for both years. So curious on the way the same tool is being used in other government institutions. So we did a quick search and found this document from another DOH-run hospital. So the National Center for Mental Health uses the following scale to interpret the scores of their satisfaction survey. Notice that for an item to be considered outstanding, the satisfaction rating should be at least 95%, which is quite different with the 90% used in our institution. Now, when I tried using this target of 95% in our facility, notice that only the aspect of the follow-up planning is not considered to be satisfactory on both years that the surveys were done. So this just shows that, and to highlight that the given quality issue in QMMC remains unaddressed. And this is a review of our conducted root cause analysis using the four-piece Ishikawa. And using this tool, we identified that the issues arising from processes, patient, policies, and provider contributed to our quality issue of concern, which is the poor follow-up planning for our chemotherapy patients. And it is important that this quality issue to be addressed since poor follow-up planning may lead to the following when unaddressed. For patients, it may lead to delay in chemotherapy, to poor patient outcomes, and to poor patient satisfaction, as we saw. And for providers, the poor follow-up planning may lead to increased strain, burnout, and reduced morale. So now let us proceed to the meat of the matter, which is the performance measures for our quality issue of concern. And please welcome Stephen and Tuan.
Good day, everyone. Next slide, please. So these are the following measures of metric that will be used to address our problem. Next slide. Our first metric of measuring the poor follow-up planning of chemotherapy patient is the cancellation rate of appointments. We look into how many appointments were canceled due to poor coordination and planning with reference to our Ishikawa diagram. It mainly affects the process arm of the discharge planning instruction, defined as the cancellation due to unable to take meds and failure to comply with pre-chemo labs. For the description, the numerator will be the number of ACU patients with appointments for chemo and whose appointments is canceled due to the reasons stated above. The denominator will be the total number of ACU patients with appointments for chemo during the study period multiplied by 100. This will be done in ACU, and the data will be collected by the officer in charge of the unit, and the data will be in a logbook of appointments for chemotherapy. This will be done every 6 months and should be verified by the head and supervisor of the ACU. Our target is to have a less than or equal to 15% based on the study estimates done in chemo cancellation rate at 13% by Fuentes et al. In 2015. Next slide. This parameter answers this part of our Ishikawa diagram, the part of the process.
Thank you, Dr. Ben. I will continue with the next parameter, which is the percentage of patients receiving chemotherapy without appointment. The performance question, how many patients have received chemotherapy but has no appointment or schedule? The domain of the HCQ timeliness. The type of the HCQ measure is the process. The level of HCQ measure is system. The definition of the terminology, patient receiving chemotherapy without appointment. This refers to an ambulatory chemotherapy patient who receives their planned chemotherapy on a date other than what is indicated in their treatment protocol. The descriptive measure formula, the numerator is the number of patients who receive chemotherapy without an appointment during the study period. And the denominator is the total number of ACU patients who receive chemotherapy during the study period. And the calculation is the numerator divided by denominator times 100%. The methodology of the measurement and collection of data. Data is collected at the ACU. Data is collected by the officer in charge of the unit. How data collected? Data is gathered from the logbook of appointments for chemotherapy and the respective patient's treatment protocol, and will be collected in every 6 months. And data will be verified by the head or supervisor of the ACU. And our target, based on the study that reports 4.6% of missed chemotherapy appointment are avoidable by Gupta et al. 2020, is less than 5%. Next slide. The indicator cover for this issue under policies issue in the Ishikawa. So I pass to Elmer.
Okay, thank you very much, Juan. So finally, for our last measure, so we present to you the percentage of patient satisfaction towards follow-up planning. So for this particular measure, it seeks to answer the question, how satisfied are the patients with their chemotherapy follow-up planning? And this measure focus on the domain of patient-centeredness, being a form of an outcome measure, hoping to describe the follow-up as a system and is experienced from the patient's point of view. So for this measure, we define the patients as those who has received chemotherapy in the ambulatory chemotherapy in our facility. And to do this, we'll be using the same patient satisfaction survey we presented earlier, which became the basis of this quality issue of interest. We will use the same formula wherein the numerator is the total number of yes to the question, and the denominator is the total number of answered questions, and the resulting value is multiplied by 100%. So for the methodology of this measure is the same we use in our satisfaction survey, done in the chemo unit by chemo patients, and then using the same tool discussed, which is answered quarterly. And for this one, our target is, as previously presented, will be 95%, comparing to the original 90% of the same institution as exemplified by the NCMH last 2023. And this particular measure is set to address this area in our root cause analysis with regards to the patient factors. So this is our references, and this is the end of our presentation. So thank you very much for your time.